Hello, good morning, everyone. Thank you for being here on time for this second day of the symposium. Yesterday, we discussed a lot about the different sepsis phenotypes and the importance of enrichment the patients we treat with sepsis. So for today, we have an important discussion on a specific phenotype with this endotoxic shock that can be treated with blood purification. This specific symposium is done with the support of Estor and Direx here in Spain. For that, we have two speakers. It's my pleasure to introduce the first speaker, which is Dr. Silvia da Rosa from Vicenza. You know that Vicenza is the epicentrum for new advances in blood purification, hemoperfusion, continuous recurrent replacement therapy, etc. And Silvia is one of the rising stars in the intensive care world, and I'm sure that he's going to give us an excellent talk about endotoxic shock identification and clinical management with Polymyxin B Hemoperfusion. Thank you.
Thank
Silvia.
you. It's an honor to be here for me. So, as we know, the pathogenesis of sepsis is based on host and pathogen interaction. We have a pro-inflammatory response characterized by excessive inflammation leading to tissue damage, and we have an activation leukocyte, an activation complemented also coagulation cascade, as we can see from this figure. And from the other side, we have an increase in immunosuppression because we have an impairment of immune cell function and also an increasing of regulatory T cells. So it is important because when we have an exacerbation of host response, we can have also organ failure. And we can have, from this organ failure, total recovery or long-term sequelae because we have a chronic critical illness because there is a persistent inflammation, immunosuppression, and catabolism syndrome also. Or probably we can lose our patient. And LPS is one of the most potent immune activators that gain prominence in the last years and can cause organ injuries, can cause kidney injuries, lung, liver, heart, and endothelium injury. And we have, if we compare with the murine models, we can have a really high sensitivity in the human body and compared to murine models that we have a really high resistance. And when we give antibiotics to our patient, we can cause such an explosion and we can have a really increase of releasing of endotoxin. And as we can see here, in all cultures from this study treated with an effective antibiotic, a decrease in bacterial counts occur after antibiotic treatment with an increase in total of free endotoxin concentration. So probably we are giving the treatment, there are antibiotics, and we can cause a side effect. Particularly, the endotoxin release is based on which kind of antibiotic we are given. And in Italy, for example, we are really high using piperacillin, and we can have a really high endotoxin release, and we can have a septic shock, but probably it's more correct to tell that in this kind of patient, we can have endotoxic shock. So what we know that during episode of severe endotoxemia, concentration of both lipopolysaccharide and its lipid core fraction are liberated from gram-negative bacteria and become elevated within the systemic circulation. Lipid core is most homogeneous and the physiological toxic segment of the lipopolysaccharide molecule, and we know that polymyxin B has profound binding avidity for the lipid A core. Probably the mechanism is based on the development of active forces, but also hydrophobic interaction. And, if we administer polymyxin B intravenously, we can have a really side effect concerning neurotoxical and also nephrotoxical side effect. So if we use a strategy based on hemoperfusion, we can go straight to endotoxin, we can remove endotoxin, and probably we can be really supportive for our patient close to antibiotic and source control. So could lowering the level of LPS in the blood treat septic shock more effectively than antibiotics alone? Probably hemoperfusion, or we can use sequential therapy that we can see later. So using also the renal replacement therapy and some really hemodiafilter, we can remove cytokines. Probably we can be also supportive. So adsorption is a mechanism that we use for hemoperfusion, and is an extracorporeal process in which molecules dissolved in plasma or blood bind to the membrane structure or to the other adsorbing substances such as resin or gels. And when we assess the device, we have to assess the device adsorption capability, that is a specific property of a single device. It can be defined as the amount of endotoxin that a single device is able to remove from the whole blood. But we have also to consider the endotoxin burden of our patient, so the quantity of circulating LPS that our patient has and that can affect by septic shock. And you know, we have a MEDI trial results and that we have endotoxic activity, say, over 0.6. So if we consider the endotoxin dose response curve, endotoxic activity value of 0.9 correspond to 4 nanogram per milliliter. And if we consider another patient with endotoxic activity 0.9, blood volume 5 liters, we have around 20 micrograms. Our endotoxin burden is equal to 20 micrograms. But if we consider interstitial space, we have to consider you know, a really high volume. And so endotoxin activity could be 0.9, it could be around 52 micrograms. So we have to find a really good device able to remove this amount of endotoxin in the blood. So in 1994, polymyxin B has been bound and immobilized to polystyrene fibers. So what we have is a covalently binding to polypropylene and polystyrene derivative fibers is such like you know, a texture can compose a roll. The roll go inside the cartridge and the blood go from the center to the peripheral wall. And how we can use it? Hemoperfusion is the mechanism. So we put high flow catheter, so dialysis catheter. The blood flow should be between 80 and 120 milliliter per minute because this is isolated hemoperfusion. And the hemoperfusion lasted 2 hours and could be applied for 2 consecutive days after 24 hours. And what we use anticoagulant is heparin, 1460 units per kilo, and you know, followed by continuous infusion. But with this device, we are just removing 64 microgram of endotoxin. So the device adsorption capacity is really high if we compare with other devices that are able to remove endotoxin. But we are not only removing endotoxin, we are also doing inflammatory control. And there is an increasing after the using of polymyxin of Direx, but also attenuation of propoptic activity. But also we can remove monocytes activate from peripheral blood of septic shock patient. We have a lot of studies. So we just to, you know, just remember the more important study. The first randomized control trial is UFAS studies. It's the first Italian randomized control trial. 10 tertiary Italian ICU, 64 patients. Polymyxin B Hemoperfusion was started in patients with evidence of abdominal shock. Was not measured endotoxin activity, and you know, was a positive trial because the absolute risk of death at 28 days improved significantly from 53% in the conventional therapy group to 32% in the polymyxin B treated group. Second trial, really important, French randomized control trial, open-label multicenter study, 240 patients. The Abdominix trial, patients were treated based on peritonitis, and was compared. The 28 days mortality was higher in polymyxin B group. But this trial was, you know, characterized by a lot of technical issue. A lot of circuit, you know, had a long lifespan, a brief lifespan. So probably, you know, those compromised the results. Euphrates randomized controlled trial is a multi-center blind sham randomized controlled trial conducting 50 ICU in the United States and Canada, 450 patients, and they consider eligible patients septic shock with the confirmed endotoxemia using endotoxic activity assay greater than 0.60. But no difference was found in 20-day all-cause mortality, but the trial showed some patients that they have really septic shock with a high endotoxin burden and the MOD score high. So an amendment to the protocol was made after the interim analysis that suggests the lack of effect in the patient with the multi-organ dysfunction score of 9 or less, and those patients were excluded thereafter. So they performed a post-hoc analysis. And they found that polymyxin has a decreasing less mortality compared to sham. But also the sham could be analyzed because they put such a catheter, and it was a fake catheter to the patient, so it was not, I think, really sham because people knew what they were doing. And as we know, probably we have a lot of literature with there is a significant mortality reduction concerning polymyxin B hemoperfusion versus control, but there are a lot of Japanese studies because in Japan is used from healthcare, so very often. If we consider study on polymyxin B hospital mortality, this was what they use for the surviving sepsis campaign at the beginning, but they exclude the study before. They include just a study into 5 years, so the old study were excluded. They, they gave a suggestion against a weak recommendation concerning endotoxin B polymyxin B hemoperfusion. But we know that probably we have improvement 28-day mortality, but also noradrenaline-free days, as we can see here. And the problem is that we don't know nothing about we are not really sure about the timing. And this is the only study that we have concerning the timing where hemoperfusion was initiated within 19 hours and reduced mortality from septic shock, especially intra-abdominal infection. And also we know that probably in SOFASCO categories of 7, 9, or 10, 12, survival is probably higher. This is what I do in my clinical practice. So we do an assessment of a patient that has septic shock, and we are just focused also on timing, because we know that probably there is a golden hour for this patient as a trauma patient, and we have to, go straight, and we have not to lose time. So we measure serum lactate, we do whatever we do for our septic shock patient, and close to antibiotic sus control, we decide based on blood culture and also on endotoxic activity assay if we have to start so confirm endotoxic shock start with the polymyxin B hemoperfusion. If our patient has kidney failure, we decide to start renal replacement therapy in sequential modality. This because kidney injury, kidney failure should be supported. So we did this also in COVID-19 patient, and we were really faster because a COVID-19 patient has super infection in after 10, 12 days, as we can see from literature. And we try to be faster, so we did it in 4 hours, not 6 hours. And this was our kind of clinical practice. And we do sequential extracorporeal therapy because we want to do a concurrent application intervention because we want to correct an alteration and restore organ crosstalk. So, but when you do this, you have to create a team, you have to have a protocol, the communication is important, the education is important, Update local epidemiological data is important. So if you have a registry, you have to do a registry concerning this kind of technique. Also, you have to avoid redundant prescription. You have not to be impulsive when you start extracorporeal blood purification. You have to be aware of pharmacokinetic and pharmacodynamic issue for antibiotics during extracorporeal blood purification, because this is a really huge issue. And you have to, have a strong team. You have to talk with your team lab. You have to keep your relationship with the nephrologist. If you have also the possibility to perform biological marker, do this, because it could be helpful in a holistic approach to your patient. So what we did in the last consensus, EDCI consensus in septic associated AKI was just to focusing on what we want to do. So when we see the patient with septic shock, and the patient has no kidney failure, we have just to perform a monomodulatory support close to sus-control antibiotic therapy. And so for this reason, endotoxin removal could be an immunomodulatory support, but also we can use renal replacement therapy to perform, if there is a kidney failure, both immunomodulatory and kidney support if we are using the right hemodia filter, able to remove cytokines. And this is a way that we use in our clinical practice in Vicenza, and this is the way that we were just focusing on this consensus that sooner we will have published. So this is data from my registry. So from UFAS registry, this is my data. What we did from 2016 to 2021, we screened 531 septic shock patient. We consider 61 patients for polymyxin hemoperfusion treatment. And until 2019, May 2019, we just using the surviving sepsis campaign definition criteria. After we try to standardize and we use first hour bundle, we use the flowchart that I showed you before, and we exclude patients with endotoxic activity assay over 0.9. So I know that probably is not really clear, but there is no difference between the two groups inside the pre-flow and post-flow chart. What was really interesting and that we have not only abdominal source, but also respiratory source of infection. We have a decreasing in all population concerning endotoxic activity assay, because from May 2019, we did also the trend, the kinetic of endotoxin activity from baseline until 120 hours. And what we saw was the decreasing of vasoactive neutrophil score, mean arterial pressure was more stable, and from enrollment until 120 hours, and also improvement of SOVA score and lactates. We have a decreasing also of inotropes and vasopressure. And what I did was also to analyze which was our using concerning renal replacement therapy after polymyxin B Hemoperfusion. So we have 82% patient that based on acute kidney injury KDIGO criteria, we had based on urinary output, serum creatinine had acute kidney injury. But also we start sequential therapy in 75.4% of patients, and 83% after the first treatment polymyxin B Hemoperfusion, 82% after the second treatment, considering overall population. And so post-flow chart, there was also an improvement of acute kidney injury. Sequential therapy in the post-flow chart was performed not only using high volume high filtration, that was the best modality used in the first group pre-flow chart. And also we have, an improvement concerning also renal recovery in post-flow chart. 61% of patients has a renal recovery compared to the other group. After we did a balance of covariates, and we found in post-flowchart group a decreasing in 90-day mortality and also decreasing in ICU mortality. There was really low, the percentage was 29% in ICU mortality. It was the same percentage in 90-day mortality. So in a comprehensive approach to endotoxic shock treatment, the evaluation of kidney function, vasopressure requirement, endotoxemia, together with SUS control antibiotic therapy based on time from sepsis diagnosis may have a role to personalize the treatment for each specific patient. Dynamic monitoring and prescription should be really helpful and useful and should be performed because we want to achieve a criteria of precision medicine, but even more specific treatment shall be provided for every moment that the patient has a particular need during his or ICU stay. So, in my opinion, Polymyxin B Hemoperfusion is a safe blood purification therapy to be considered for management of unresponsive endotoxic shock, resulting with clinical benefit for patients. Thank you.
Thank you, Silvia. We're going to have the questions at the end. We're going to have a debate at the end. So we are going to move on to the next speaker. Next speaker is Dr. Luis Aguilera. He's coming from here, from Barcelona. He's working in Hospital del Mar, which is a wonderful hospital with very nice views close to the beach. So he's working in the surgical intensive care, and he's going to tell us about his experience with Polymyxin B in septic shock after abdominal surgery. Thank you.
Good morning, Dr. Ferrer, and thank you for inviting me. It's a very honor to come back home. I studied medicine here, so it's very, very impressive to be in this side of the room. I will try to ask you what are we doing here? What are we doing here? Because last recommendations of the surviving sepsis campaign in 2021, they said there is not sufficient evidence to make recommendations for the use of blood purification techniques, or even more, they suggest against the use of Polymyxin B. So I ask myself, and I ask you, what are we doing here at 8 in the morning talking about this topic? I will try to share with you our clinical experience. I will not make reviews of the literature. I won't talk about meta-analysis or whatever, but just talk about the patient, which is the focus of our job. This is a postoperative patient with this in a very severe condition, which is intubated, having monitoring, having renal replacement therapy. This is, I think, the patient we should focus on to use the techniques of blood purification. A few review of the septic shock, and Silvia did it very perfectly. I remember that sepsis is a dysregulated response to an infection, and when it leads to profound circulatory, cellular, and metabolic normalities, then we have a septic shock, which is characterized with a very high mortality rate. As it was stated on the previous talk, the infection triggers a response who activates all the immune system with a dysregulated response, leading to dysfunction or organic dysfunction. So endotoxin should be our therapeutic target because on the actions it makes on the system leads to septic shock and organ dysfunction. So how we treat sepsis, as is already stated, with supportive treatment, initial resuscitation with hemodynamic management, ventilation, renal replacement therapies if necessary, and nutrition in the late days. It's very important to choose the right antimicrobial treatment adapted to the local flora and to the condition of the patient and to the site of the infection. For us, it's very important the source control, whatever is surgery, drains, removing of infected catheters, and we are talking about the additional therapies, corticosteroids, which are really recommended, but there are other therapies who leads us to the future. The future, as Jordi Relo states in a very nice review, should be personalized or even precision medicine. In the meanwhile, is there a place for both blood perfusion techniques? Blood perfusion techniques, we talk about adsorptive therapies, which act by the passage of blood through filter circulations with a membrane that adsorbs mediators pro-inflammatory, as really stated Silvia before. We can use in a lot of conditions, in septic patients after cardiac surgery, pancreatitis, burns, illness with very high inflammatory response. There are many devices, but we are talking about Polymyxin B. It works in an extracorporeal circuit, and the interaction between the endotoxin and the sorbent is made by hydrophobic interaction, ionic forces, and van der Waals forces. Just remember that Polymyxin B is an antibiotic who breaks the permeability of the cellular membrane of the gram-negative bacteria, but it has a very, very high renal toxicity. This is why it is used only in a immobilized filter column and used in the setting of the renal replacement therapies for endotoxin removal, leading to a decrease in endotoxemia through absorption and with the object to reduce the inflammatory response. I will share with you our clinical practice guideline, how we use Polymyxin B in the Hospital del Mar. This is a very simple protocol that it allows at every moment of the year, no matters if morning, date, weekends, Christmas Day, and every physician who attends the unit could use it in a very, very single way with the support of nursing teams. When we use Polymyxin B, we use it in Septic Shock, which is from the abdominal origin, and which is suspect to cause by a gram-negative bacteria in order our local microbiology. In a patient who, despite effective focus control, despite an adequate initial resuscitation and optimal administration of antimicrobials, his state is no improving or even worsening after 6 hours of treatment. We characterize that, but the already known signs of persistent multi-organic failure. We focus it in the first 12 hours. It's difficult to say when the sepsis starts, but we use it 12 hours before or after the end of the surgery. Of course, the patient has not to be in a life support limitation. There are many contraindications in severe thrombocytopenic patients or hypersensibility or young patients or pregnant women. There are some side effects, the coagulation of the systems and cutaneous erythema, and when a mild tachycardia or an hypotension when the renal replacement starts as always. We use the standard renal replacement therapy machine, and our treatment, as is stated, is 2 hours, repeated at 24 hours through an usual dialysis catheter. It's a blood circuit only, no replacement therapies, no dialysis. We start the circuit with 5 liters of saline at a blood flow, usual blood flow described by the Toray industries, and with the anticoagulation systems. This is an scheme of what I showed you. I will show our experience. We start using Polymyxin B in 2014. As I said before, we use it in patients of abdominal origin sepsis, which are refractory to the treatments, and which is suspect or confirmed done by a gram-negative bacteria. Unfortunately, we do not have gram stains of the majority of our patients. We analyze in a baseline time before the start of the treatment, and after 48 and 120 hours, the SOFA score, hemodynamic variables, laboratory parameters, mortality at 28 and 90 days. So we use it in 23 times in 8 years. This is really a very low number of patients, but we try to select it for a very, very ill patients. But I think the patients were really, really ill. The mortality we saw is 17% at 28 days and 26% at 90 days. The site of the infection were most of it in the colon, and then the small bowel. All the patients had a similar antimicrobial treatment before the start of the therapy. Most of them had meropenem and linezolid with antifungical and other combinations. And the final microbiology found on the patients, most of them were gram-negative bacteria. This is the main numbers we found. Focus on the SOFA decrease over time, like those of norepinephrine, like procalcitonin, lactate, and protein reactive C protein. This is the numbers converted to an image. The numbers which are higher decrease. Here we could see it, the norepinephrine, SOFA, and lactate, which you can see the decrease of the parameters. When we talk of mortality, we ask us, this is very high, this is low, this is usual. We try to analyze all the 6 patients who died in this series. 3 of the patients died a few days after the therapy because of bad evolution of the illness. But one patient died at day 24 because of acute mesenteric ischemia, maybe due to all the process. And 2 more patients died many days after. One of the patients was an intestinal occlusion, and we show that her illness was progressing. And what we have in our surgical intensive care unit, we have around 50 septic shocks a year, most of them in men, with a SOFA score not as high as we in the patient we use polymyxin, and our mortality rate is similar at the patients we use polymyxin. With all the data I share with you, our conclusions should be that there is a place for polymyxin B therapy when it's added to conventional treatment in a very, very ill patients and provides a significant improvement in our patient who had a refractory septic shock. But we insist we should use it only in selected patients who are very ill and who are having a very bad evolution, clinical evolution. And we are aware that we have no access to endotoxin activity. This is we are fighting to have. We don't know exactly the role of the conventional treatment which is ongoing when we start the treatment with polymyxin B. And as always said, we need more patients to determine exactly what is the usefulness of this therapy in the patients with septic shock. And with this, this is the image you can see on the mornings when we go to work. So it's 20 minutes walking from here. And I made a short presentation, but part of it was most of me done by Sylvia, so I tried to go faster and try to share with you our clinical experience. Thank you very much.
Thank you both for the excellent presentations. Please come to the table because we have some minutes for discussion. There is any question coming from the floor? Yes, there is one question in the third row, please.
I have a question for the experts. Is the duration? Because in your presentation you say 24 hours, no? Mm-hmm. And you, Sylvia, also something similar. So the question is, do we need to prolong the treatment in patients with, especially for abdominal surgery or sepsis from abdominal infections, where normally it takes long time to recover, and they have a sustained high level of endotoxin? So,
if I understood, you mean the duration of hemoperfusion?
Yeah. No, on the hemoperfusion, well, on
because
on
the duration
absorption.
of hemoperfusion is 2 hours, but I do second treatment after 24 hours. Yeah, so are 2 treatments in total. And I do endotoxic activity assay trend. And also, if there is a shock resolution, you don't need to put another treatment with this cartridge. Because you have, I think that probably the endpoint should be shock resolution, not mortality for this kind of treatment. Because we are just doing with there is endotoxic shock, not just because patient has sepsis. So probably shock resolution should be the end point, but we are working on because mortality is not enough, and was a hot topic also on the consensus for sepsis-associated AKI, just to understand if probably target or shock resolution could be the right end point for this kind of patient. But if you don't need to use it because you have a shock resolution, your patient is well, you have not to use this kind of treatment more. This is my opinion.
In patients that you
Because-
don't have an excellent resolution in 24 hours, and sometimes there are a rebound when you stop your treatment. This is a question that I am asking because in the group of Massimo Antonelli, this was one of the questions with no answer. I mean, in patients with severe sepsis, normally it's a disease that is prolonged more
Yeah,
than
but
24
the timing
hours.
is important because I think that before starting with this treatment, you should be aware about sepsis. So I think that probably there are another stuff that in the hospital should be performed because sometimes when the emergency team is called, the patient is just in a severe phase of septic shock. So probably the sepsis recognition and after the sepsis and the sepsis shock recognition, the call for a team that come to assess the patient could be, I think, the first step. And after, the time on this treatment should be, in 12 hours at least. But if you go over, it's too late because this is a adjunct therapy, this is a bridge therapy. You have to start with antibiotics. If there is a sus control, surgical sus control, you have to do it, but you have to be faster. So recognition probably is the first step, I think, in a hospital. But sometimes when we see the patient, it's too late because there is a late recognition of sepsis. Are you agree?
Yeah, I fully agree. So this is part of the workflow we have with these patients. Probably when you start with these therapies in your hospital, you start with more a rescue approach. So those patients, I see that you're using in patients with very high dose of norepinephrine, and then you try with the experience to move more a preemptive approach of treating, of identifying the patients that may respond to this therapy earlier. Did you see this evolution with your experience? Did you change a little bit the
Not
approach?
at all, because it's unfortunately the patients who died the first day after the start of the therapy are one of the last ones we treat. So these patients, it's difficult to analyze that dose for us, for me, when analyzing data, to see if they are with a. We use it earlier. I could not state that. And also we have also some. We use it in the same way. We use during 2 hours, and then at 24 hours we repeat the same. We never try to make a third treatment. It is not recommended, so we do not use it.
We have time for a short question, Professor Artigas.
Just a question of information. Is there any plan for the future on a new randomized control trial?
Well, there is so the Direx trial is being done in the US. It's let's say an adaptation of the Euphrates trial following the subgroup analysis done, as Silvia mentioned, in the subgroup of patients with multi-organ failure and endotoxin activity between 0.6 and 0.9, which is where it seems to concentrate the benefit. As chair of the session, I will take the privilege, despite we are 30 seconds late, to have another question for Silvia, because I am very interested in this trend in endotoxin activity. Not many centers have the possibility of doing that. So did you identify, in terms of endotoxin activity, responders and non-responders, and how this affect your decisions on the topic Professor Artigas was
Probably
saying?
G50.
Yeah.
Yeah, we did a sub-analysis using, we find a center that were experts concerning this kind of treatment, and those experts did the trend of endotoxic activity assay, and we find responder and non-responder the improvement in survivors, yes, but we will see sooner, probably publish sooner, this data. So there is a difference.
Okay, so it's time to move to the next session. So thank you very much to both speakers.
Thank you.
And thank you for being here in this early session, and thank you, of course, to Estor for supporting us.
Thank you.